webinar corresponds to the very last part of the lecture covering the cardiac cycle. In particular, this webinar covers factors that affect the pumping effectiveness of the heart. We're going to look at normal regulation of the heart, including intrinsic and extrinsic regulation of the heart. We'll also look at the role of things like ions, temperature, various hormones, a lot of different things that can affect the heart's effectiveness. The cardiac output, which you see as abbreviated as CO, this is the volume of blood that the heart, or you should say each side of the heart, pumps out each minute. It is calculated by taking the person's heart rate, which is expressed in beats per minute, and multiplying it by their stroke volume, which is expressed in liters, or it also could be in mils. The stroke volume, remember, is defined as the volume of blood pumped out of each ventricle. So cardiac output is taking it one step further. How much each ventricle pumps out per minute? The average cardiac output, or I should say a representative cardiac output, incorporating men and women together, is about 5 liters per minute. Gentlemen, your cardiac outputs are obviously higher than the females. It averages about 5.6 liters per minute. The females averages about 4.5 liters per minute. That's why if you average them together, it's about 5 liters per minute. That would be under resting conditions. Now, the cardiac output is very variable, so it depends on what's going on. It is going to be, if you compare rest versus sleeping and exercise, it will be the lowest while you're sleeping. It'll be the highest while you're exercising, because it's very much related to your level of metabolism. The cardiac output is a very good indicator of blood flow through peripheral tissues. If you don't have adequate blood flow, you can't maintain homeostasis. So we very strongly regulate our cardiac output so we have adequate supply of blood to peripheral tissues. So that's why it's kind of very much linked to your metabolism. When I'm exercising, my peripheral tissues need a lot more blood, so I can get a lot more oxygen, a lot more nutrients, and I need to get rid of waste products. Just kind of give you kind of a frame of reference where cardiac outputs can get up to high as maybe 40 liters per minute, say like someone like a marathon runner or a cyclist. They can get extremely high. And how we can get cardiac output so high is by affecting things like heart rate and stroke volume. Heart rate can increase by about 250%, and stroke volumes can nearly double. So if I need to alter my cardiac output, I can alter my heart rate or my stroke volume. Well, first thing we're going to discuss is look at the intrinsic regulation of cardiac output. Would be the intrinsic factors that alter cardiac output, things like having to do with characteristics of the myocardium itself. So this is without outside factors such as the nervous system or hormones. This is truly innate. So we kind of say it's like your heart in a petri dish. So I've got your heart by itself with no nerves, nothing. It can regulate its own cardiac output. So this includes something called Frank-Starling mechanism of the heart, which we've already discussed. This is, remember, the more in, more out rule of the heart. So Frank-Starling says that the higher the venous return, which would end up being a higher end diastolic volume, the greater the force of contraction, therefore the greater the stroke volume. So if I increase stroke volume, cardiac output would go up. So remember, cardiac output is equal to stroke volume times heart rate. So if you give the heart more blood, it will pump more out. So that's kind of an innate type thing. Also, another way that you have intrinsic regulation of cardiac output is by affecting heart rate, a thing called atrial stretch. When you have an increased volume coming to the heart, what it does is it stretches out those P cells, which are pacemaker cells that we have located in the right atrium. Well, when you stretch out P cells, it increases their membrane permeability, increasing their firing rate. So when they fire more rapidly, heart rate goes up. So they call this thing called atrial stretch. With atrial stretch, because of the stretch of those P cells, you get about a 10 to 15% increase in heart rate. So if you bring more volume back to the heart, you not only get an increase in heart rate, and it has just innate, so those P cells that are located within the heart itself, you get an increase in heart rate, plus you get an increase in contractility because of the Frank-Starling mechanism, which increases your stroke volume. Both of those combined would increase cardiac output. However, intrinsic regulation is limited. It can only increase cardiac output a little bit, which won't help, like say if I want to exercise, if I want to run a marathon, if I want to run a 4-minute mile, you're going to need some extrinsic regulation of cardiac output. So when you talk about extrinsic regulation, we're starting to refer to things like as the nervous system or the endocrine regulation, hormones, which would be kind of humoral factors, things found in tissue fluids. The extrinsic regulation also could be things in regards to changes in ion balance. The most important normal physiologic regulation of cardiac output is the nervous system, and specifically the autonomic nervous system. So we're going to spend a little bit more time talking about that. But things like norepinephrine and epinephrine released by the adrenal medulla, these are hormones which also can affect cardiac output. But there's also some, would see more, instead of not physiological, things that are more pathologic. Other things like changes in metabolism, temperature, ions, those also can affect cardiac output. What we're going to do is spend a little time talking about the autonomic nervous system's regulation. So first thing I have to mention is this intrinsic rate. If I did not have these nerves attached at all to the heart would continuously pump inside your heart because of that, the heart having its own conduction system, its own electrical cells that can spontaneously generate its own impulse. And the intrinsic rate is based on the pacemaker of the heart, and the pacemaker of the heart is in the SA node. They have a depolarization rate of anywhere from 60 to 100 beats per minute. It's got a relatively wide range. On average, it tends to be a little bit more on the higher side, but that's the intrinsic rate of the heart. That's without any influence of outside factors. However, under normal conditions, we do have both parasympathetic and sympathetic input to the heart. These are two components of your autonomic nervous system. They both innervate the heart. They have different effects on the heart, and they innervate slightly differently, which consequently also leads to the different effects to their heart. So I want to discuss the innervation and their effects that each have. Now, the parasympathetic branch of the nervous system comes from the vagus nerve, or vagus nerves, okay? The vagus innervates the SA node, AV node, and the atrial myocardium, but it has very few, if any, fibers that terminate on ventricular muscle. Okay, so that's important. So parasympathetic is going to go via the vagus. It innervates the SA node, which is up here, the AV node, and just maybe slightly the atrial muscle, but pretty much does not innervate the ventricular muscle. So I want you to think of it, think of what's going to be the result of this. So one thing I want you to keep in mind, if something innervates the SA node or AV node, they will have effects on heart rate because these are components of our cardiac conduction system, the system that initiates the depolarization and transmits it through the heart. If something innervates the muscle, it will affect contractility. So, the vagus terminates on the SA node and AV node. So obviously, it's going to affect heart rate. But how is it going to affect heart rate? The SA node, the vagus, the neurotransmitter released by the nerve endings, is acetylcholine. What acetylcholine does is it opens chemically gated potassium channels. What that will do is slow the rate of spontaneous depolarization, and it'll slightly extend the duration of repolarization. So let's think about it. If you slow the rate of spontaneous depolarization, you slightly extend the duration of repolarization, what will it do to heart rate? What it does is it slows your heart rate. Think about parasympathetics. It's about rest and digest that slow things down. So what it'll do is slow your heart rate down. Now, since the vagus does not innervate the ventricular myocardium, it does not affect contractility. It has slight effects on contractility of the atria, but for the most part, just ignore or think of the parasympathetics not really affecting contractility, since the importance of contractility comes from the ventricles. So overall, the parasympathetics slow heart rate. The sympathetics. Well, the sympathetics emerge from the thoracic region of your spinal cord. The nerves extend out, and it innervates SA node, AV node, and most areas of your myocardium. So pretty much everywhere. So the sympathetics innervate the ventricular myocardium, unlike the parasympathetics. So it's going to affect heart rate and contractility. So what does it do? Sympathetics. Okay, the sympathetic nerves, they release, their neurotransmitter that they release is norepinephrine. And it binds on the SA node and AV node, and also the myocardium, beta-1 adrenergic receptors. That's important. Norepinephrine binds to beta-1 adrenergic receptors on the SA node, AV node, and the parts of the ventricular muscle. What it does, it leads to opening of calcium channels. An influx of calcium, what it'll do is increase the rate of depolarization, and it'll shorten the period of repolarization. So what's going to happen? What affects the nodal cells, so SA node up here, AV node down here, it's going to allow those nodal cells to reach threshold more quickly, so heart rate goes up. So heart rate goes up. What does it do to contractility? Got more calcium available to the muscle, it's definitely going to increase contractility. So when you're in sympathetic mode, you're in fight or flight, you want the heart to be able to pump out more blood to the tissues. So heart rate goes up. When you increase contractility, that will allow stroke volume to go up. So we've got parasympathetics that slow down heart rate, sympathetics that increase heart rate, and also increase contractility. Now, both of these divisions are working at the same time. It's not like sympathetics are on, parasympathetics are off. They're actually both active at a steady background level. Which is more active at that time determines, is the heart rate going to be higher or lower, or the effects in contractility. So if you're just sitting here listening to lecture, or just kind of barely conscious, you're going to be in more parasympathetic mode. So your heart rate's going to be a little bit lower than the intrinsic rate. When you're, say, getting up, starting to work out, you're being more sympathetic mode, heart rate's going to be a little bit higher. Contractility is going to be higher. Think of it as sympathetics being the accelerator in your car, parasympathetics being the brake. And you get those people that drive with their feet on the brake and the accelerator at the same time. And you know there's some people out there that do that. So if I want to slow down my heart, what are my options? You will press down the brake or let off the accelerator. That's going to slow down your car. If I want to speed up the car, let off the brake, push down the accelerator, and or. Both of them can happen at the same time. So think of that going on with the heart. Now we do have limitations to our heart rate. Your maximum heart rate is age dependent. As we get older, our maximum heart rate does decline as we age. That's why when you work with a trainer and they want to know, try to figure out what your target for working out, they kind of give a rough idea what your max heart rate is by taking 220 and subtracting your age. So the older you get, the max heart rate goes down. But that is just a rough estimate. To get an actual max heart rate, you do need to do a stress test. But let's just give you a general idea. But we do have limitations on our heart rate. The autonomic nervous system is a very important regulator of how this heart's working, but there's other things that can affect the effectiveness of the heart. You have humoral regulation. So these are presence of stuff in tissue fluids. One example would be the output of epinephrine and norepinephrine from the adrenal medulla, which is inner region of the adrenal gland. It affects your metabolism, it affects your circulation, it affects the respiration, it affects a lot of different stuff. This is definitely going to be important when you're in sympathetic mode. So when you're in sympathetic mode, you have the release of neurotransmitters by the sympathetic nerve endings, but you also have the release of these catecholamines, epinephrine and norepinephrine, from the adrenal medulla, which then will have effects. And again, it will have effects on the heart because you have those beta-1 adrenergic receptors on the cells of the conduction system and cells of the muscle. So it's an important thing to kind of keep in mind. A lot of people don't realize that as long as you have receptors on a target tissue, you will have an effect. So if I have a heart transplant, when they do heart transplants, they disconnect the nerves attachment to your heart. Obviously, take out the bad heart, and they're going to put the new heart in. Well, obviously they make sure all the blood vessels are back in place, but they do not reattach the nerves. So they always say heart transplant surgeons are very good plumbers, but not really good electricians. But that heart will continue to beat in that person's heart, in their chest wall. Someone will say, well, can't they ever exercise again? At some point, yes, because when they're, say, exercising, they still will release epinephrine and norepinephrine from the adrenal medulla, and that will have effects on heart rate and contractility because the receptors are still there. You don't need the innervation from the nerves. So as long as you have those receptors, you can still have the effects of those catecholamines released by the adrenal medulla. Now what I want to do, it's going to be kind of moving ahead from what we just discussed, talking about changes in contractility, changes in the heart, and give you some fancy terminology that you need to associate with these different effects on the heart. So the first one is term inotropic effect. Now if something has an inotropic effect on the heart, it's said to affect contractility of the heart. Now it can have a positive inotropic effect or a negative inotropic effect. So if I say something has a positive inotropic effect, what you need to write down is that it increases cardiac contractility. Okay, so positive inotropic effect It increases cardiac contractility. Examples would be epinephrine, norepinephrine. So you had epinephrine, norepinephrine released by the adrenal medulla. You had norepinephrine released by the sympathetic nerve endings. They increase cardiac contractility. Thyroid hormones also do that. And another one is glucagon. You learn in biochemistry about glucagon, its effect on maintaining blood sugar levels. But it also is widely used in cardiac emergencies, especially before synthetic agents became available. So glucagon also increases cardiac contractility. There's a lot of drugs out there that do it. One of them is digitalis. So digitalis, what that does, it helps to elevate the intracellular calcium levels, and it interferes with the removal of calcium from the sarcoplasmic reticulum. So it keeps those extracellular fluid levels of calcium a little bit higher. And ultimately, everything when we talk about inotropic effects in the heart, it's linked to calcium in some way, shape, or form. And digitalis is a drug often given to patients with in heart failure to help to increase the contractility of their heart. Now, if I say something has a negative inotropic effect, that would be some agent that decreases cardiac contractility. So these would be things that maybe block calcium movement or somehow depress cardiac muscle metabolism in some way, shape, or form. So a negative inotropic agent decreases contractility. So examples, anything, if I inhibit the sympathetic nervous system, obviously I'm not going to have the effects of norepinephrine there. Anoxia, that's lack of oxygen. Acidosis, some hypertensive medications. Beta blockers, they will also decrease contractility. And any calcium channel blockers, that would also decrease contractility. So you have agents that affect contractility, those have inotropic effects. Now, if I administered something to you and your heart rate was affected, it would be considered to have a chronotropic effect, chrono meaning time. So just like when we mentioned the inotropic factors, we have things that have positive chronotropic and things that have negative chronotropic effects. So if I ask you, what is the effect of something that is said to have a positive chronotropic effect on the heart? You would say that would do what to heart rate? You would say it increases heart rate. So a positive chronotropic factor increases heart rate. If it has a negative chronotropic effect, it decreases heart rate. So example of something that would have a positive chronotropic effect would be sympathetics, norepinephrine, epinephrine. That would also increase heart rate. Something that would decrease heart rate would be the parasympathetic, stimulation of the parasympathetics, acetylcholine, because that's released by the parasympathetic nerve endings. That decreases heart rate. Now, in these two topics below, or concepts that follow chronotropic effect, actually fall under chronotropic effect. I probably should have had these indented. These two terms are referred to heart rate. If I have bradycardia, I have a heart rate less than 60 beats per minute. That is the definition of bradycardia. You have bradycardia if your heart rate is less than 60 beats per minute. Do not by any way, shape, or form define bradycardia as a slow heart rate. No, that will not work for me. Bradycardia is if your heart rate is less than 60 beats per minute. Now, having a heart rate less than 60 beats per minute is not necessarily a bad thing. Very physically fit people have resting heart rates under 60, even under 50. Some have resting heart rates of 30 beats per minute. Think of it as a beneficial effect of endurance type training, because a slowly beating heart is more energy efficient than one that beats more rapidly, as long as their stroke volume is enough that their cardiac output is sufficient. But bradycardia is not necessarily a bad thing. Tachycardia is defined as a heart rate greater than 100 beats per minute. So do not define tachycardia as a fast heart rate. Will not work again. It's a heart rate greater than 100 beats per minute. So if I have a heart rate of 100 beats per minute, is that okay? It's not tachycardia. It's got to be over 100 beats per minute. So when would you have tachycardia? We have it when we're young. Newborns have resting heart rates about 120 beats per minute. Heart rates start to decline as we get older. Now, something normal at your heart rate would be over 100. You're exercising. Someone's freaked you out. That's okay. But if your heart rate's over 100 beats per minute, resting all the time, probably not a good thing. Your heart's having to work too much all the time. The good thing to kind of keep in mind with how you would kind of know the cutoffs for bradycardia and tachycardia is if you know the spontaneous depolarization rate of the SA node, which is the pacemaker of our heart. That sets that basic rate of your heart, and the rate for the SA node is between 60 and 100 beats per minute. That's why you have the cutoffs as you do. Bradycardia, less than 60 beats per minute. Tachycardia, a heart rate greater than 100 beats per minute. Anything between 60 and 100 is normal. Some other terminology, talking about the heart, would be if the heart was hypoeffective or hypereffective. You should know what the prefixes hypo and hyper mean. So if I have a hypoeffective heart, my heart's not as an effective pump. If I have a hyper-effective heart, that's something that's making my heart more effective or more effective pump. So if you have something that makes the heart a less effective pump, somehow it's decreasing the pumping effectiveness of the heart. So let's think what it could be. Things like valvular disease. So if I have defective heart valves, congenital heart disease. People are born with defects within the heart, like septal defect, hypoxia, insufficient oxygen, various toxins. A lot of different things can cause the heart to be hypoeffective. So here, where you're getting into cardiac outputs less than 5 liters per minute on average. Again, remember, girls, your cardiac outputs are a little bit less, but something that's making your cardiac output a lot less than it's supposed to be. Hypereffective heart, this is something that increases the pumping effectiveness of the heart. Things like nervous excitation, so stimulation of the sympathetics, which would happen, say, during exercise, and also to an extent hypertrophy of the heart. With marathon runners, they've got tremendous sympathetic stimulation while they're running, plus they've got hypertrophy. That is going to allow them to get to cardiac outputs up to 40 liters per minute. Now, having a hypereffective heart is not necessarily a bad thing, but sometimes it can be too much. But generally think of this as more of a better thing. But think of like during exercise, you definitely want your heart to be hypereffective. So here, your cardiac output is going to be higher than normal. Now, examples of things that can make the heart hypoeffective, besides the ones I already gave you, would be ion imbalances. Okay, so we're going to two last topics we're going to talk about is the effect of ions on the heart and the effects of temperature. So let's give you a big overview before we look at each individual one. When we talk about the effects of ions on the heart, it's not really a simple discussion, and I'm not going to go too in depth because it'll just blow your minds. So we're just going to give you some basic fundamental things I want you to remember. When you think about ions on the heart, ions play a very important role in action potential generations. You have several cations that you learned about that are crucial for the production of action potentials in nerves and muscle fibers. So it's not surprising that if you have an ionic imbalance, that can compromise the generation of action potentials and contractility. Where it becomes complicated is some ions affect the movement or action of other ions. That's where it becomes a little bit complicated. So we're just going to give you some general overviews of ion imbalances and what it can do to the heart. We're going to look at 3 ions: potassium, calcium, and sodium. Those are all very important cations. And a little quick reminder, what's a cation? That's an ion, something that's charged, and it has a positive charge. Of the 3, the potassium imbalances are considered to be clinically the most significant. It's not that if you have imbalances with calcium or sodium, they won't hurt you. Those 2 ions have a lot more regulation. We regulate those ions a lot more carefully than we do potassium. So potassium ions seem to be more difficult to deal with. Now we're going to first start with the effects of potassium. If you see this, the Kal, that is it's Greek, and that refers to potassium. So if I have hyperkalemia, that means it means I have a condition of the blood, the emia, in which I have higher than normal levels of potassium. So here, if I took a blood sample from you and we did a chemistry profile, your potassium levels would be higher than normal. So you have too much potassium. Different causes, and this is not a blanket list, it's just some examples. Most often hyperkalemia is caused from kidney disease because your kidneys play a very important role in potassium levels. So about 3/4 of the cases of hyperkalemia is because someone has renal disease. But other things that can cause hyperkalemia: crushing injuries or burns. And the idea here, how you can remember this, is normally most of your potassium should be found inside the cells. So if you have massive cell damage, all that potassium leaks out and you'll get hyperkalemia. So burns, crushing injuries definitely would do that. So if people have significant burn injury, crushing injury, besides of all the other problems they have to deal with, they definitely have to worry about hyperkalemia too. Here's something maybe you guys would probably encounter most, is if you have a patient at your clinic and you get some people who like take this and this and this and this for everything. They take all these different supplements. Overuse of supplements can lead to hyperkalemia because what's contained in those supplements. So someone uses a lot of different supplements. So I'm taking this vitamin for this and this for that. That can lead to hyperkalemia. What happens is with the higher levels of potassium, it affects the resting membrane potential, it affects your action potentials, it affects contractility. Now, I don't care that you remember that what you have here, membrane potential is closer to threshold. It shortens your action potential. It decreases contractility. What I want you to remember is what hyperkalemia is, a couple examples of what can cause hyperkalemia, the fact that it will not make your heart very effective. It is an example of something that will make your heart hypoeffective. And the fact where it can lead to particular changes on the electrocardiogram. In your notes, you only have one example, but it does some other stuff. But we're just giving you something that's pretty for this one, almost, not absolutely, hallmark of hyperkalemia. It's changes in the T wave. Now here's a normal EKG, PQRST. You can start with hyperkalemia, start getting the T wave becoming a little bit more peaked, and even as it gets worse, even more peaked. So tall peak T waves can be associated with hyperkalemia. But I have to let you know that T-wave abnormalities are not diagnostic of particular conditions. They can suggest certain things, but other things obviously have to be done to diagnose this. Obviously, hyperkalemia would be diagnosed by doing a blood test. Oh, your blood potassium levels are high. Oh, I can see why you have this tall peak T-wave. You can get tall peak T-waves if someone's in the evolution of having a heart attack. But generally, if someone's not exhibiting some of the symptoms of a heart attack, and they've got you do an EKG and do some blood tests, this is pretty diagnostic of hyperkalemia. But don't say it's absolutely diagnostic of it. But you start seeing T-wave changes. With hypokalemia, you also get T-wave changes. Now with this one, hypokalemia literally means a condition of the blood where you have lower than normal potassium levels. So with hypokalemia, it again is something that will not make your heart be all that effective. It will affect membrane potentials again, action potentials. It leads to things like arrhythmias. Now arrhythmia literally means lack of rhythm. Better term would be dysrhythmia. So you don't get that regular rhythm that you should with the heart, which probably not going to make your heart work all that effective. Muscle's not going to be all that strong. It will make the heart hypoeffective. That's what I really want to make sure you just understand. Ion imbalances will affect the pumping effectiveness of the heart. Hypokalemia, some of the causes, certain diuretics. Diuretics are often given to people with high blood pressure. There are multiple examples of diuretics out there. So there's some diuretics that we call non-potassium sparing diuretics. So they cause these people to lose a lot of potassium in the result of taking these diuretics. Generally, physicians know this, that this is what it does. So they tell the patient that this can cause you to lose potassium, so you need to make sure you supplement your diet with some more potassium. Eat a few bananas. But if the patient doesn't do that, or maybe they don't get the medication quite right, it can lead to hypokalemia. Also, heavy laxative use or excessive diarrhea can lead to hypokalemia. The loss of that intestinal contents can cause loss of potassium. So lots of times these patients with hypokalemia may say they feel fluttering in their chest, the heart's skipping a beat, they got irregular heartbeats. And what happens is it can have changes on the EKG, which by no means, shape, or form diagnostic of hypokalemia, because what you see on the screen can be seen with other conditions. So you have to obviously do a blood test. Okay. So with hypokalemia, the T wave may start getting smaller, and it's followed by a U wave. So again, it kind of follows alphabetical order: Q, R, S, T, U. So you see that in this case, the T wave can start to merge with the U wave. So the T wave can shorten, and you can actually get more of a U wave. With that, usually if you start seeing U waves, usually indicates things that are delaying repolarization, which could happen with hypokalemia. So overall, again, with changes of potassium, you need to know the definitions of hyper and hypokalemia, general causes of them, the some classic ECG changes that may be associated with those conditions, and overall that they make the heart relatively hypoeffective. That's what I want you to remember. Now calcium, you learn about calcium plays a very important role in muscle contraction. It's definitely going to play a role in the generation of action potentials in slow response cells, which you'd see in the nodal cells in the heart. Very important in that plateau phase when we talk about muscle cells. So calcium, if the calcium is not maintained at an adequate level, normal level, it can cause problems with the heart. Now here it says seldom a clinical problem. Well, it can be a clinical problem, but generally we have a lot of systems in place that strongly regulate calcium. We have hormones such as parathyroid hormone. We've got vitamin D. You've got calcitonin. These things try to keep calcium in very strict range because calcium imbalances affect nerves, it affects muscle, it affects a lot of different stuff. But now we're just talking about specifically cardiac muscle. Now if you associate calcium with muscle contraction, you would pretty much say, oh, more calcium, a little bit more contraction. And you would be perfectly right. If you have hypercalcemia, that means if I took your blood sample, you would have higher than normal calcium levels in your blood. Now that is associated with the cardiac muscle have increased contractility. They're more excitable, plus the cardiac muscle cells contractions are more powerful and prolonged, and they'll use the term spastic. So with hypercalcemia, the cardiac muscle is spastic. In extreme cases, the heart can go in an extended state of contraction that obviously would be generally fatal, because if the heart doesn't relax, it won't fill up with blood. With hypocalcemia, this is where you have lower than normal calcium levels in the blood. This would be associated with decreased cardiac contractility. The contractions are very weak, and at some point they may cease altogether. Now, the cardiac muscle is much more dependent on the extracellular fluid levels of calcium because cardiac muscle fibers, the sarcoplasmic reticulum in those cardiac muscle fibers have less calcium than the sarcoplasmic reticulum or skeletal muscle. So if you don't have enough calcium in the extracellular fluid, cardiac muscle is going to be much more susceptible to that than, say, skeletal muscle. Without sufficient amount of calcium, the muscle cell will be very weak, the contraction will be weak, and they'll use the term it's flaccid. Okay, so use the term flaccid. Sodium, changes in sodium, again, not as often a clinical problem, generally associated, though, having to do with hydration issues. You either consume too much water or not enough water. So I'll give you an example. Well, let's define a couple things for you first and kind of give you an example, which is because of it's a hydration issue. Hypernatremia means a condition of the blood where you have higher than normal sodium levels. So I can have hypernatremia not because someone just dumped a whole amount of sodium in my blood, but rather that I've lost fluid, I'm dehydrated. So the concentration of sodium I have is higher than normal, and it's because I'm dehydrated. If I drink a whole lot of water, short amount of time, don't use the restroom, I can develop hyponatremia. They call it water intoxication because you got the same amount of sodium, but all this water in there, so the concentration of sodium is less. So often the times it's because of hydration issues. Well, lots of times with changes in sodium levels, oftentimes you're going to see a lot more problems with the central nervous system. But again, since we're talking about the cardiac muscle, we're going to talk about what it does to the cardiac muscle. Sodium is one of those that affects calcium movement. So if you have a lot of sodium, like in hypernatremia, it blocks calcium influx during the cardiac action potentials. So therefore, it has effects on contraction, actually decreases the force of contraction. It leads to arrhythmias. Again, so arrhythmias are where the basic rhythm of the heart is not normal. It deviates from the normal, what we call a normal sinus rhythm. And if you have this lack of proper rhythm, a heart will not be an effective pump. You can have tachycardia. And what is the definition of tachycardia? Don't say fast heart rate. It's a heart rate greater than 100 beats per minute. Okay? So it can lead to arrhythmias. Hyponatremia could lead to a lethal arrhythmia. All arrhythmias could be lethal, but cardiac fibrillation is definitely lethal. If you do not get this back into its normal rhythm very quickly, the person will die. So cardiac fibrillation is where the heart is not working as a pump. It's not coordinated in any way, shape, or form. So both of these conditions can have significant effects on the heart. We say seldom a clinical problem because we have, again, a lot of systems in place to help to regulate sodium levels. A lot of hormone systems that will help to keep the sodium concentrations in a relatively constant or narrow range. So, but again, obviously it can still be a problem because these people appear in the emergency room all the time with hyper and hyponatremia. Now, the last thing that can affect heart function is temperature. And it kind of can come along the lines of one of these things too. If I'm outside in Texas, middle of summer, outside in the sun, maybe even exercising, probably not a good idea, and I'm not drinking, I'm going to get dehydrated, but also have the effects of the temperature. Temperature affects heart function too. So what temperature does, it affects the permeability of the membrane to ions. So remember, ion movement across the membrane affects action potentials, going to affect contraction, all that good stuff. So let's think about how temperature can affect heart function. If I have a reduction in temperature, what that does is it slows the rate of depolarization of the SA node because it affects sodium movement across that membrane. It's going to lower the heart rate, and it also reduces the strength of cardiac contractions. So it affects calcium movement too. So you reduce temperature, it slows heart rate, it decreases contractility. Think about when this may be important. Well, during open heart surgeries, the exposed heart may be deliberately chilled until it stops beating. Because what hypothermia will do is it slows metabolism. If I slow the metabolism of the heart by decreasing contractility, decreasing heart rate, it reduces the oxygen needs of tissues, which allows the heart and the brain to withstand short periods of interrupted blood flow during the procedure. Maybe they need to do something, they're doing a heart transplant or doing something in which they have to reduce blood flow to the heart or the parts of your body. Let's deliberately chill the body or chill the heart. Think about people that fall into the ice in the middle of winter and they survived with minimum damage to these people because the reduction in temperature decreases the people's metabolism, so they were able to withstand the lack of oxygen and nutrients because their metabolism was greatly slowed. Now let's think at the other end of the spectrum, an increase in temperature. If you increase temperature, that's going to speed up movement of things across the membrane. That increases heart rate and increases contractility. So that's one reason when you exercise that your heart, it has increased heart rate, increased contractility because you get a slight increase in temperature, but mainly it's because of the nervous system excitation or stimulation of the heart. But think about when you're running a fever. A lot of people will notice when they're running a fever, their heart seems to race and pound because the increase in temperature. That has the effects on heart rate and contractility. So overall, we have things that have physiologic effects on heart function, the autonomic nervous system, various hormones. We have things that affect heart function that maybe are pharmacologic agents, certain drugs. We have ion imbalances that can affect heart function. Temperature can affect heart function. Now we also, in this lecture, we learned a lot of terminology, a lot of definitions. So make sure you understand those definitions. This will be not the only time you ever hear of chronotropic or inotropic or tachycardia, bradycardia. This is not the only trimester you're ever going to hear those terms. So make sure you understand the terminology. So this is the end of the lecture on cardiac cycle.